And congratulations to you and your team on this first virtual LDC conference. The three aims of my talk this morning are to outline the contractual process so far, what has been agreed to date, and what future contractual arrangements may look like. Go move to the next slide.
Your slide yourself.
Mm-hmm. Clicking the arrow.
You may have to use Windows tab to go back to PowerPoint.
Yeah. Okay. Are you seeing a new slide now?
Yep, your slide's up there, Sean. You can carry on.
That's great. Thank you.
That's it.
Okay, great. So you're delighted to know that I only have a handful of slides. It's useful to reflect on where we are and how we arrived here, and hopefully indicate where we may be going, the principles that were developed for the future framework. It's been an interesting journey, protracted, difficult, but important to get to an agreed decision with a pragmatic approach. At the start of lockdown, NHS practices were facing collapse without an appropriate and timely financial support. And that wasn't a given at the time of lockdown. And myself and the BDA team are grateful to the NHSE team, particularly Matt Nelligan and Carol Rees, who realized the risk and committed to the support early on. And this slide is the position now. So back to face when it's appropriate. And I just wanted to pick out a couple of points. The no abatement. So NHSE have accepted the argument that there were increased costs, that PPE was the obvious one, but not the only one. They originally proposed counting just the completed courses of treatment, but we felt that it was important that remote triage, telephone and video contact with patients be included, as that is valuable and often the most appropriate form of patient care. This represents a high trust relationship and environment, and this is something that the profession has been asking for a very long time, and the onus on the profession to deliver that trust now. Hand in hand with that trust relationship is an ambition and objective to decouple from the widget counting and to be rid of UDAs. So Q3 and Q4, the remainder of this financial year, I've kept the two slides, the next two slides, deliberately broad to encourage debate later. And in essence, all suggestions for these next 2 quarters need to be able to work within the existing contractual framework. It's agreed on both sides that there needs to be some simplicity because this is going to be needed to introduce very quickly, Q3 and Q4. The current contract is too complex. It's opaque for dentists and patients. And the trust element here is worth repeating. It's very important on both sides. There'll be 3 key themes, I think, around Q3 and Q4. The first of those will be access, i.e. patient numbers. Traditionally, we've talked about capitation, looking after a cohort of patients. Secondly, health inequalities is an important theme that is consistently raised. That's the groups of deprivation, the homeless, care homes, and the just about managing groups, those that are not exempt from charges but find it difficult to afford. And how do we accommodate the high needs patients that the current system frankly doesn't encourage us to see? And thirdly, prevention. So thanks to Sarah Hurley and Eric Rooney for their continued support of prevention and the move away from the UDA system. But prevention, for it to be meaningful, needs to be appropriately funded and financially supported. Prevention will involve DCPs and educators, and we know about the outreach clinics, the fluoride, the brushing programs that are possible, but none of it is meaningful unless the financial package is in place. Building on what has been developed, but ramped up with a financial package to make it achievable. So what of the future? There is ambition for contract reform on both sides. It's entirely appropriate for the patient oral health care for 2020 and beyond, for this generation and the next generation of dentists. No UDAs, caring for a patient population, prevention embedded and financially supported, and an established clinical pathway that is valued by dentists and patients alike. Now, dental contract reform has obviously taken far too long, but it has established principles that can be delivered, but only with the appropriate package in place. We must secure practice sustainability, improve access, and reduce oral health inequality. And if we reach those goals, we can achieve an oral health care system fit for purpose for 2020 and beyond. So over to you. The idea of this particular item was to bring you up to date with some of the conversations that we're currently having about quarters 3 and 4. And I think we'd welcome thoughts, concepts, principles, and new ideas that may be relevant for that period, but also more importantly, beyond that, when we can hopefully move away from the UDA system. A list of questions, frankly, is not what we want at the moment. We're looking for ideas. Questions will come another time. Please make as many contributions as possible. I'm conscious how many people are on this conference, and not everybody will be able to contribute visually. Please use the chat bar. If you want to follow this a little bit more, my Twitter address is there if you want to follow me on Twitter. And thank you for listening.
Right, well, thanks very much there, Sean. And I think this is food for thought. And Sean has asked you for some comments on this. And I know that Zoe Connolly has given this an awful lot of thought. And we're going to hear from her first, actually. So can we play what Zoe's prepared something for us in advance. So over to you, Zoe, please.
In June 2018, I stood before this conference, desperate for change. Together, we carried forward a motion in support of contract reform, not only for the profession, but for our patients. And here I am, over 2 years later, an associate working in an NHS practice, uncertain of the future. I'm no longer asking for change, I'm demanding it. What have we learned in the last 2 years about contract reform? Well, we've been told that the prototypes have been progressing well, that dentists and patients like the pathway and the new way of working, and more practices have joined the contract reform process. But we also know that some practices have left because of the targets and the financial pressures. I work in one of those practices that left the prototype system. Access was one issue and UDAs were the other, and NHS England were told over and over again that access and UDA targets blended together just don't work. And now here we are living through a worldwide pandemic, and our current outdated contract doesn't work. NHS England and the Treasury have been left squabbling about how they can pay dentists when we're not providing UDAs. If there was ever a time to be rid of the UDA, it's now. There will be talk about flexible commissioning and starting well campaigns, but we shouldn't be asking for a temporary fix. We need a permanent change, and we need it now. Sean, you're asking for what we need. Well, we need a capitation-based system with reasonable access targets where we're allowed to look after our patients, where we can provide preventative advice to prevent future disease and help our patients to maintain their own oral health. We could have a more detailed treatment menu to design treatment plans appropriate to their needs. The inbuilt perverse incentives of UDA targets need to be removed. Fee per item for advanced treatments could be reconsidered. A quality outcomes framework could be developed. Why don't we monitor the things that are important for our patients' oral health, such as targeted oral hygiene and diet advice, fluoride varnish applications, oral cancer screening, rather than a meaningless counting system like the UDA, which has never been in the best interest of our patients' oral health. The worry has always been the risk of supervised neglect in a capitation system, and this could and should be monitored, and there are systems in place for this to be workable, existing dental practice advisors, or even extending the remit of the CQC. NHS England are trusting us now, so let's show them as a profession that we are to be trusted with the needs of the patients that we look after. Our patients need us to be there for them, so I'm asking Conference to get involved in this opportunity to develop a contract which is centred around us and our patients' oral health. All of us here want change, and the time really is now.
Okay, well, that was Zoe there. And I know that people are putting their hands up to speak, and we will get to you. But just before we do, I know Simon Hernshaw had something to add. Simon.
Yeah, good morning, Conference. As Zoe, Sean and Dave say, contract reform is absolutely long overdue. We don't need UDAs and we don't need narrow activity targets. So what do we need? I think we need, or we think we need, in fact, a more outcomes-based care system, maintaining and even increasing access to high-quality continuing care and urgent care, improving oral health and reducing inequalities, reducing child GAs, integrating oral health care within general health care. We need to be able to use every single team member optimally. We want to be able to support PCM priorities. We need the NHS to be the best place to work, especially for younger colleagues with careers ahead of them like Zoe. So what could this look like? As Zoe says, perhaps a capitation-based system with reasonable access asks, weighted to reflect local needs. A strong prevention focus using a whole team approach, use of DCR care pathways, plus perhaps a raft of flexible commissioning type programs targeting prevention in and out of the practice, periodontal disease, caries management, outreach prevention and treatment programs, targeted inequalities in care homes, schools in deprived areas, and for the homeless and socially marginalised. We need to invest in our workforce, upskilling our teams to deliver skill mixed care, developing formalised peer review to drive quality improvement, training, accrediting and resourcing level 2 clinical networks to provide more complex care within our communities. All of this exists in one form or another. It just needs developing into a commissioning framework. And finally, what have we learned from COVID? We've learned that primary dental care can have effective input into care change management. Primary dental care can work collaboratively with commissioners to develop responsive services. Primary dental care working with LDCs and LDNs can deliver hugely impressive outcomes for patients, even in very, very difficult circumstances. And we've also learned how much oral health care is valued and what the impact is when it's constrained. So the challenge, as Zoe, Sean and Dave say, is to harness the impressive dental COVID response to build a better future service, one that improves care for patients, underpins access, focuses on prevention, delivers outcomes, not widgets, reduces inequalities, and crucially provides sustainability for all NHS practices. Thank you.
Okay, right. Thank you very much there. Now we have Tony Clough who's asked to speak. So Tony, could you have are you ready to go with your mute off and your video?
Yeah, hi. Thank you very much for giving me the opportunity. I have to agree 100% with Sean when he talks about the necessity for a high trust environment. And I agree with all his aspirations towards that. The thing that concerns me, certainly working through the pandemic, is that we're seeing practices that are not opening, that are not actually, if you like, pulling their weight, practices that are charging for PPE, practices that are capitalizing on what I can only describe as the COVID pound and charging in the region of £300 or £400 for extractions. How are we to actually persuade the commissioners that we can work in this high trust environment when we have colleagues that are doing this? And I'm just wondering, as a profession, whether these people should be hung out to dry. Thank you very much.
Okay, thanks very much for that. Now, I understand that some people are still having problems raising their hands to speak. It may be that people are using the reaction button, but the raise hand function is within the participants button there. That's where you find it. But I have got Henrik Overgaard Nielsen next. So over to you, Henrik.
Thank you very much, dear. Good morning, conference. I think it's an interesting concept, this new way of doing the conference, but I think so far you're doing very well. So thank you very much for that. I just want to say a few words about this. I completely agree with both Sean and with Zoe. It is extremely important now that we get a capitation-based system. We cannot continue with a system that's activity-based, not in the current situation. We are not going to be able to see the same number of patients and do the same amount of treatment as we've done before. We need a capitation-based system. Flexible commission, Simon, is absolutely fine, but it is a bit around the edges of this. We need a national system based on capitation. And I think if there ever was a time when we can get through with that, the time is now. And I think it would be a travesty if we do not grab this chance and actually come up with a new system that we have worked for so long to get. And it is long, long overdue. Thank you very much.
Thank you very much there, Henrik. Now, keep feeding back to Sean through the chat, because even if you're not speaking to conference, he's going to take back anything that you've written. And I don't have anyone else with their hand up for the moment, but if you do want to, oh, here we go. No, we have Gillian Cottam. So Gillian, over to you.
Thank you, conference. I'd just like to echo what Henrik has just said. I do think you have to be careful what you ask for, and that you don't end up with a PDS system like Ortho that is time limited, which may be the hidden agenda, and where you get a fixed fee where there are no swings and roundabouts. It's just a set limit for everything. Thank you.
Oh, thank you for that. Now, if you are trying to raise your hand and it's not working for you, mention it in chat and I'll get my team to feed back to me for that. But while we're waiting, in case there are some people who can't get their hand up, I'm going to ask Ian Gordon to speak here because I believe he has something to add.
Thanks very much, Leah. That's been a really helpful debate, and it's absolutely pivotal that we take this opportunity and get this right. I'm not going to be negative or trying not to appear negative, but there's a little bit of agree with Jill, be careful what you wish for. There are some traps around whether this became a time-limited contract, and that could be very damaging. If we look back to item of service to pre-2006, there was a lot wrong with that. There was perverse incentives, there was 400 plus codes, but there were some things that we gave up. There's definitely been de-skilling of the profession. People lost the ability to do surgical extractions or to go to care homes. And we lost the ability to expand our practices at the rate we wanted to expand them. And we're completely under the control of NHS England. John Renshaw warned about this in the early part of the 2000s and said, there's real dangers here of an NHS land grab, and you're going to lose a lot of the control that has allowed you to develop the businesses that you've got. And John was absolutely right. And we have, of course, been blessed by world-class NHS commissioning for every NHS contract that's ever come up since 2006. And they've always got it so spot on in terms of how the service is being developed. So we've got to be really careful that we don't do the same thing here. Now, I'm not advocating continuing the UDA, but just let's be mindful that there could be some bear traps here that we could fall into. And it's quite clear that NHS England, Department of Health, the Treasury will want a metric, and they will be judging us on that metric. I've worked in PDS Plus contracts, and instead of it just being a UDA barrier, we had decoff barriers, we had patient access barriers. So you could get clawed back on 3 different measures. The prototypes, as we know, the biggest challenge was maintaining patient numbers, and therefore you were likely to get clawed back on not keeping patient numbers. So these are all things that we can learn of what's not gone wrong. And of course, the hardest thing is learning what might go right. Completely agree with Zoe. This is an opportunity to do things, but we've got to be mindful of the pitfalls. And we may need to start with what we've got now. We know the UDA shouldn't be used as it is, but Barry Cockcroft used to talk about a basket of indicators. He used to say that it could be done differently. It never was, and that was more commissioning error. So maybe we need to look at what we could do now. We could look at flexible contracts, we could look at blended contracts, we could look at what's right for any individual practice. Does that practice benefit from capitation? Can it look after its patients by capitation? Or is it very high needs and it needs a lot more funding through item of service? I'm sorry I haven't got the answers, but that's my sort of summary of the things that we need to be considered. And just be careful of that NHS England land grab. I got an email from one of the NHS commissioners today saying that she'd like to see the UDCs continuing for a considerable period of time. Well, that's fine, but UDCs didn't necessarily sign up in the COVID response to be an urgent dental centre for another 12 or 18 months with no other income stream, with its own cohort of patients to look after. That's the sort of land grab I'm talking about. We've got to be mindful from, that they don't end up absolutely continuing to take control of our businesses in the way that they have over the COVID period. You will do this, you will wear that, you will have this length of time for an appointment. That's not how I would like to see the profession go. It's not the profession I've worked in and developed businesses in for 35 years. So let's just be careful as well that we get the right deal that isn't a gift to NHS England of the businesses we've all worked so hard to build up. Thank you for listening, and nobody's pressed the mute button to shut me up yet, so I'll end now.
Thanks very much for that. Now, we're going over to Duncan Thomas in a sec. So Duncan, if you could get ready, but we're seeing in the chat there seems to be concerns over supervised neglect and calls for DROs. So let's hear what Duncan has to say.
Hi, I've just got an interesting perspective, well, at least I think it is anyway. We too were involved with the pilots and then the prototyping system and left in April 2019. The main reason we left was because instead of having one metric of UDAs, we ended up with 3 different metrics to try and meet, and 3 challenges to try and meet every year, resulting in higher clawback than we had under a UDA contract. And whilst the clinical pathway is really, really good, it's something that works very well. I found, the practice found,
I've got a spreadsheet of different polls I've got to do, and I've got
certainly found that the
not letting me doing it on this machine because what he's saying.
Bino, I think your mic's on there. Yeah, carry on there, Duncan, sorry.
Right, yeah. We found that the different metrics were quite a challenge for us to be able to meet. And I came to the conclusion that the underlying fundamental problem was that we were receiving the same amount of money to treat the same number of patients. And it was the inadequacy of the funding of the contract that was a problem, rather than the system.
Okay, right, thank you very much. Now, I don't appear to have anybody else with their hands up, and I'm not getting any messages there. So I think what we'll do is we'll go back to Sean now. And Sean, has that assisted you?
No, that's great. And I've just been following the chat, and there's an awful lot of input there. Just to try and pick upon a few themes, you know, initial thoughts, I suppose, really. I mean, there is an opportunity here. There's an opportunity that has developed as a result of something that none of us could have predicted, i.e. COVID. Picking up on Duncan's theme, I think, yes, if we're not careful, we can end up being asked to jump through more hoops for essentially the same package. And I'm not sure that's doable. And that's something that we need to be very aware of. Picking up on Ian's contribution, you know, looking for the traps, if you like. There are going to be traps, and we need to ensure that practices maintain their flexibility, because there are obviously different scenarios for different practices all over the country. It needs to be a flexible enough approach where people can be accommodated, practices can be accommodated. I think the trust environment is important. I think lots of comments on the chat about 90% and 10%, it may be 95%, it may be 5%. But broadly, the vast majority of the profession have and continue to do the right thing. What we mustn't allow to happen is the very small minority to undermine what is an absolutely crucial period for the majority of practices. In essence, I think if we don't grab this opportunity now within the next 6 to 9 months, I think we could be waiting a very long time. So we're certainly mindful of that at the BDA. As I say, early conversations around Q3, Q4 are important. They'll need to deliver something fairly quickly, and by definition, it will need to be fairly simple. But I think if those principles become established and they're successful, that will probably be the foundation for what we hope is a new contract and moving away from the dreaded UDAs with all of the issues that, you know, we well know about and well rehearsed. So what I would say is, if there is, and I'd be interested, you know, from the conference, we've had a fairly limited amount of time to talk about this for understandable reasons this morning, but it may be that if people want it, we could perhaps develop something that you know, allows more debate, perhaps a longer period of time, and, you know, give your indications on the chat bar as to whether that would be something that would be useful. And I think I'll leave it at that. But thank you, Leah, and thank you for all your contributions.